So kita start yang HSS kan, betul?
Boleh. Sekarang.
Untuk HSS, glycemic hyperosmolar state, it's memang adalah acute emergency in diabetic patient lah, sama macam DKA, is different of diagnostic criteria lah. Sama juga untuk HSS memang kena manage intensively in HDU ataupun equivalent level of care. Elderly with comorbidities more prone to HSS, however, epidemiologically shift of type 1 DM in younger group. So currently we found HSS in younger age of group lah. It has higher mortality than DKA and vascular complication, for example, MI, stroke, peripheral arterial thrombosis. This one is quite common. Seizure, cerebral edema, osmotic demyelination syndrome. Rapid changes in osmolality during treatment may precipitate osmotic demyelination syndrome. DKA present rapidly within hours, but HSS progress over many days, sometimes can be 1 week to outblown to have that full criteria to diagnose HSS. So that's why we can the dehydration level of and metabolic disturbance of HSS patient more extreme and severe lah. So how to diagnose? With marked hyperglycemia, DST usually more than 30 millimole, hypovolemia, and serum osmolality more than 320 milliosmol. Macam mana nak serum osmolality? Kita ambil sodium, darab 2 tambah glukos. What if we have the patient DST high, HI, so we might need to send the RBS lah. So we wait for RBS, then we can calculate. Untuk sodium, kita boleh tengok daripada VBG. Usually VBG tak accurate macam daripada RP lah. Tapi still we can estimate how bad the osmolality state of the patient with uncontrolled DM. Other diagnostic criteria, there is no significant hyperketonemia, which is kalau kita hantar urine keton, memang tak ada, usually kita tak akan nampak keton 1+ pun. VBG not acidotic, pH more than 7.3, bicarb more than 15. Basically normal VBG, normal blood gas. When acidosis is present, causes of acidosis such as acid and toxicology screen need to be investigated. The presence of acute cognitive impairment may be associated with edema in severe cases, significant electrolyte disturbances, hyperosmolality more than 330, sudden drop in osmolality. This one we found during the treatment of the HSS, severe dehydration, underlying infection and sepsis, hypoglycemia during treatment. Macam kita dah start insulin regime untuk patient HSS tapi kita tak check regularly of the DST, and also underlying renal failure. Clinical features of dehydration in HSS can be very difficult to detect lah, deceptive, because it may not reflect the severity of the fluid depletion. In HSS, we have hypertonicity state. So this state of hypertonicity preserve intravascular volume. Water move out from the intracellular to extracellular. Bila kita check pulse volume, kita rasa pulse volume good. Kita check IVC clinically warm periphery. Tapi in yang keadaan sebenar dia, sel dia tengah deprived, masa dehydrated intracellularly. So what is the precipitating factors for HSS? Same with DKA, mostly the same lah. Infection, thrombotic stroke, intracranial hemorrhage, silent myocardial infarction, and pulmonary embolism. What is the goal of treatment? We want to normalize the osmolality. We want to replace fluid and electrolyte losses, to normalize blood glucose, and to prevent complication. This is the, I have one more picture yang lagi. Okay. Okay, this is algorithm sama juga macam DKA. Algorithm untuk management of HSS. This one I took from latest CPG. Initial evaluation of the so we take history and physical examination, obtain X-ray and venous blood gases, basic baseline blood investigation, FBC, urine analysis, plasma glucose, RP, LFT, and as well as ECG. We nak tengok baseline ECG lah if got ischemic changes or hyperglycaemic changes. Chest X-ray and cultures as needed lah. Chest X-ray to rule out CAP or underlying infection, pulmonary infection, and cultures if patient presented with fever or we septic looking or we suspect any underlying infections going. So we'll start IV fluid 1 liter normal saline per hour initially. This one is the diagnostic criteria, sama macam saya sebut tadi, blood DST 33.3, pH normal, more than 7.3 by cup, more than 15, not like DKA, mild ketonuria and all ketonemia, and effective serum osmolality when we count sodium times 2 plus glucose, blood glucose 300, more than 320 milliosmol. IV fluid. How much to give? We need to determine clinically the hydration status. If the patient in hypovolemic shock or mild hypotension or in cardiogenic shock. If the patient if in hypovolemic shock, we can give normal saline or any plasma expanders. If the patient is mild hypotensive, we can evaluate corrected serum sodium. So if serum sodium high, we can change to 0.5 half saline, depending on the state of hydration lah. We want to give 4 to 15 ml per kg per hour, or we want to give normal saline. It's same 4 to 15 ml per kg per hour depending on the state of hydration. This one applicated for high serum sodium or normal serum sodium. If the serum sodium is low, we give normal saline 4 to 15 ml per kg per hour. For the insulin, macam kalau DKA 0.1 unit per kg per hour fit scale IV insulin infusion, tapi kalau untuk HSS half, which is 0.05 unit per kg per hour IVI insulin infusion. So firstly, once we started the insulin, we need to check the serum glucose hourly. If serum glucose does not fall by at least 3 millimole per liter in first hour, we can double the insulin dose hourly until glucose fall at a steady hourly in rate of 3 to 4 millimole per liter. So bila glucose dah sampai 14 millimole per liter, we can change to dextrose 5% and decrease insulin back to initial feed scale 0.05 unit per kg per hour, or we can change to dextrose 10% with insulin rate 0.1 unit per kg per hour, sama macam DKA, in order to maintain serum glucose between 8 to 12 millimole per liter. Untuk potassium, sama macam DKA juga. Serum potassium less than 3.5, we give 40 milliequivalent potassium per hour until potassium more than 3.3 millimole per liter. If serum potassium more than 5 millimole per liter, we do not give any potassium, but we need to check potassium 2 hourly lah. If serum potassium more than 3.3, but in between 3.3 to 5 millimole per liter, we give 20 to 30 millimole per liter in each pint lah, in order to keep the potassium 4 to 5 millimole. Same with the DKA, we need to check RP every 2 to 4 hours until stable. After resolution of HSR, the patient is nil if TMBM lah, we need continue IV insulin and supplement with insulin as needed. When the patient can eat, initiate subcutaneous insulin and previous treatment regime and assess metabolic control. API insulin 1 to 2 hours after we give subcutaneous insulin to ensure control of initiating daily regime. What is the immediate management? Hydration lah. Hydration, we have IV drip. We will use IV drip normal saline and monitor osmolality regularly. This one to prevent any harmful repeat changes osmolality. As Dr. Fairuz during a slide before, too much or too fast to repeat changes in osmolality might be harmful to the patient lah. The rate of dehydration, assessing combination of initial severity and existing comorbidity. Rapid dehydration in patient with heart failure. So if insufficient refrigeration, we fail to review it. So kena hati-hati. Kalau terlalu cepat, tiba-tiba end up patient jadi failure lah. Failure. Kalau insufficient rehydration, kita tak boleh nak reverse, patient will become state KI. An initial rise in sodium is expected and is not in itself an indication for hypoglycemia. Thereafter, the rate of fall of plasma sodium should not exceed 10 in within 24 hours. The immediate management, the fall in blood glucose should be no more than 5 mmol per liter per hour. Jangan laju sangatlah untuk correct DST. Low dose IV insulin 0.05 units per kg per hour once blood glucose is no longer falling. In IV fluids alone or immediately if there is significant ketonemia. Prophylactic low molecular weight heparin, kalau kita nak bagi heparin, is recommended unless the patient is contraindicated for any heparin or clexane. Electrolyte, hyperkalemia, hypokalemia, hypophosphatemia, hypomagnesemia are common and should be corrected accordingly lah. Acutely ill patient, if there is fever, if there is no fever. If sepsis is highly suspicious, the source of infection should be found and treated lah accordingly. When we want to discharge the patient, the discharge planning includes diabetes education, patient referral, education on medication, and insulin administration if patient is on insulin to reduce the risk of recurrence and prevent long-term complication. Okay, so yang juga kita hepatitiskan patient untuk 2 ke 3 hari this to prevent venous or arterial thrombosis. Okay.
Okay, so with regards to HSS, dia compare to DKA tu, HSS it's more to do with electrolyte lah dengan osmolarity punya problem lah. So compared to DKA, HSS ni dia punya onset is more insidious. Dia bukan DKA ni can be quite acute. History biasa 2-3 hari je. Tapi with HSS onset tu lebih insidious lah. Kadang-kadang over a few weeks apa semua lah. So and the common presentation usually makcik-pakcik tua datang dengan lethargic lah. And they are commonly type 2 diabetic lah rather than type 1. So presentation insidious, they over few weeks, presentation usually very non-specific complaint, usually lethargic. Tapi the telling features, kalau compare dengan DKA, dia lack acidosis and dia lack ketonuria. Ketonemia lah. Dia tak ada keton. Dia because the difference is patient ni bukan macam kalau DKA, there's absolute absence of insulin kan, so tak boleh nak metabolize glucose at all. Tapi dalam konteks HSS ni insulin dia ada cuma tak cukup, and so dia punya acidosis is not as bad unless ada accompanying kidney failure lah, and dia punya ketone tak ada because the metabolism of glucose is still going. Walaupun mungkin tak cukup, tapi tak adalah sampai body tu have to resort to produce ketone bodies untuk metabolism. So problem dia lebih kepada dehydration, and then because osmolarity dalam intravascular space tu lebih tinggi, and you cause fluid keluar lah daripada intracellular pergi, fluid ni dia pergi ke tempat yang pekat kan. So you got fluid shift from intracellular to extracellular lah. So that leads to the problem lah. And the main thing dia sama juga macam DKA, the aim management is hydration, insulin dan sebagainya. Tapi seperti mana dia punya onset tu slow, you treatment pun kena slow. You tak boleh nak aim, nak correct within 1 or 2 days. Sometimes it takes few days. And the aim macam I think Shafiq duk cerita tadi, sodium pun kena slow, potassium pun kena slow, hydration pun kena correct over few days. Sebab you don't want the osmolarity to change very rapidly. So yang osmolarity change rapidly ni yang menyebabkan cerebral edema dan sebagainya. Yang ni yang akan menyebabkan problem, long term problem lah. And the area that we're interested in selalu brain lah, yang usually very sensitive to benda-benda macam ni. Okay, so sebab once brain dah edema, skull ni kan macam is a close punya vault kan. So kalau cerebral edema, dia tak boleh mengembang, dan you cause hypoxia, you can cause infarction dan sebagainya lah. Ni akan menyebabkan patient worse. So, tapi apa yang kena ingat, DKA dan HSS kedua-duanya can be a presentation, a symptoms rather than underlying cause. And most commonly, benda ni is triggered by infection lah. It can be as simple as URTI or pneumonia or COVID or UTI lah, which is common in elderly apa semua kan. And this can present kat you as HSS or DKA. That's why kita pun kata kalau patient DKA apa semua, you have to look for apa yang trigger DKA tu. Commonly by far, infection lah. That's why kalau patient DKA apa semua, walaupun tak ada fever, apa, kita akan suruh ambil blood culture, start antibiotics dan semua. Sebab kadang-kadang the DKA itself can be a presentation of fever. And kalau elderly, HSS ni, stroke pun boleh menyebabkan dia dapat HSS lah. So it's even more important for you to be careful in managing ni. Dia beza DKA dengan HSS ni. DKA ni treatment lebih, kita kata rapid lah. Walaupun tak rapid mana juga, tapi HSS ni lagi slow, you kena go from it. Tapi dua-dua require close monitoring lah. Okay. So, and jangan lupa cari underlying cause lah. Semua underlying cause ni serious-serious semuanya. MI lah, kan, ICB lah. So, just be aware lah. Dia, so secara prinsip dia, both HSS and DKA, the management will revolve around monitoring tu. That's why kita nak patient, this kind of patient masuk ICU or masuk HDU lah. Tapi, kita kat Malaysia resources are a bit scarce kan. So, macam buat apa yang boleh lah. Okay. So, ada soalan tak pasal HSS kepada Shafiq? Shafiq, okay?
Saya, sebab saya macam tak pernah jumpa lagi HSS kat ED. Semua
Tak jumpa
macam
lagi?
macam ni. Tak jumpa lagi.
Lalu banyak je HSS ni. Tapi itulah, kadang-kadang HSS ni dia lambat kita label sebagai HSS sebab nak tunggu urea tu lah biasanya, tunggu urea apa semua lah. So kena ingat the magic number tu 320 320 kalau pakai formula yang ada urea 330 330 kalau pakai formula yang ada urea, dan 320 kalau formula yang tak ada urea lah. Okay, so this is ni adalah kriteria for diagnosing HSS and berbeza dengan DKA more than 11 je kan. Yang ni dia mark
11.
hyperglycemia more than 30. So tapi in the end what you need to realise, benda ni adalah label sahaja. Management is the same. Still kena bagi insulin, still kena bagi fluid. Cuma whether awak nak label sebagai apa, pada saya tu tak penting sangat sebenarnya. Bila kata dalam managing diabetic emergency, HSS, DKA, label salah saya tak kisah sangat. Tapi management tu kena betul. Sebab management dia in the end adalah fluid
Insulin.
dan insulin. Dan yang penting sekali adalah monitoring tu. Bila awak start treatment, monitoring tu, kena close monitoring tu. Walaupun label awak salah, tapi awak monitor dengan betul, insyaAllah tak ada harm lah, welcome to your patient. Dan satu lagi yang saya nak cuba didik korang-korang semua, stop giving bolus insulin Patient my DKA bagi bolus insulin 8. Itu tak perlu, it's not practice anymore. If patient DKA terus start insulin infusion, tak perlu dah bagi bolus insulin 8 unit, 10 unit apa semua, because bolus insulin tu can cause more harm than helpful to patient. So macam yang kita duk discuss tadi, kita punya aim is not to bring the insulin down too quickly. Bila awak bagi bolus, dia akan jadi unpredictable insulin punya drop tu. Sugar punya drop tu. Awak nak aim 5 millimol per liter per hour kan. So kalau awak bagi bolus, lepas tu awak bagi infusion pula, the initial part of sugar drop tu akan jadi unpredictable. Mungkin akan drop terlalu cepat. Dan ataupun kalau tak drop, awak rasa nak kena increase infusion ke patient take sometimes to absorb the insulin ke dan sebagainya. So stop giving boluses for patient yang ada DKA or datang-datang sugar 30. Stop giving boluses, assess dulu. Okay, even and sometimes if sugar dia memang tinggi sangat, memang nak kena start insulin infusion lah. Sama juga kalau patient datang say for diabetic food yang awak rasa macam nak kena op or abscess mana-mana, sugar dia tinggi, don't give boluses. Start terus insulin infusion. Sebab if patient going to OT pun
Insulin
infusion juga. So bila awak bagi bolus, it cause more unpredictability in the sugar punya drop tu. Sama juga kalau patient yang NBM, sebab going for surgery ke apa, sugar dia high, tak perlu bother dengan insulin boluses, just start insulin infusion. It gives you a much more reliable and more predictable sugar drop. Tak adalah patient tiba-tiba hypoglycemia ke apa. So ni benda yang kita cuba nak kikis lah, amalan tradisi yang kita cuba nak kikis. Tapi mungkin setengah-setengah MO tu dah susah sebab dah sebati dalam darah daging mereka kan. Korang ni masih rebung-rebung buluh ni mungkin boleh dilentur lagi lah. So bila besar esok tak buat lah benda-benda macam patient DKA bagi bolus dulu. Patient DKA nak bagi backup dulu. Tak, melentur buluh biarlah dari rebungnya. So gitulah. So stop the practice of giving boluses. If you think patient require more control sugar dia, start insulin infusion. Okay. Ada soalan apa-apa lagi tak?
Doktor, patient HSS DKA memang kena KMBM ke ataupun kita boleh allow sip of water ke?
Okay, if dalam konteks DKA HSS not so much. Tadi dalam konteks DKA, kalau baca banyak buku, dia tak specify patient kena NBM ke apa. And this is something yang macam tengok awak tanya siapa. Secara prinsip dia, siapa yang propose, siapa yang menyokong ke arah NBM ni, sebab kadang-kadang patient with DKA, one of the presentation is persistent vomiting. So the reasoning is keep NBM sebab takut bagi makan dia vomit, takut aspirate lah. Okay, so saya personally tak ada, and satu lagi, one of the theory is bila patient DKA, bowel motility, gut motility, because electrolyte imbalance, kadang-kadang dia ada ileus, gut motility is reduced, apa semua, so senang muntah lah. So at least in the initial part for severe DKA, kalau saya, I'll keep NBM sebab takut potentially kita nak secure airway, or if patient ni macam duk muntah, saya akan keep NBM lah. Takut bagi muntah, aspirate dan sebagainya. Tapi kalau patient tu macam mild DKA, moderate DKA yang tak ada muntah, tak ada apa, it's okay for you. Patient nak minum, bagilah minum. Tak ada masalah. Tapi janganlah dia nak nasi kandar, bagi nasi kandar pula. So, nak minum, bagi something yang, you know, taklah heavy sangat. You know, lapik perut, try dengan roti dan sebagainya. Boleh. Pada saya, bukanlah absolutely kena NBM. Tapi kalau ada contraindication macam persistent vomiting, patient drowsy, or patient tachypneic, or rasa potentially nak intubate this patient, apa semua, mungkin keep NBM dululah. Kena NBM tu kena ada reason lah. And tapi kena selalu assess lah. Nak NBM lagi ke, nak allow ke, sebab masa datang awak NBM, tapi the NBM tu kadang-kadang carry forward sampai dalam ward. NBM sampai satu tahap dah 3 hari tu. Kenapa NBM Entahlah kenapa NBM. Sebab sebelum ni kata NBM, saya continue je. Sebelum ni sebenarnya tak ada good reason NBM. So pada saya DKA secara prinsipal dia, kalau ikut buku, most buku will say in the initial part keep NBM. Reason dia sebab itulah takut patient ada persistent vomiting. Lepas tu dia punya gut motility reduce lah. Takut senang muntah. Tapi kalau setakat sips of water apa semua tu, bagilah. Tapi kalau patient tak ada vomiting, tak ada evidence of ileus ke apa, saya rasa boleh je bagi, tak ada masalah pun. The main thing is to monitor patient lah. And tailor to, tengoklah patient macam mana. Kalau patient yang single digit bicarb, duk tachypneic tu, janganlah nak bagi makan pula. Kan nak intubate nanti kan keluar nasi kandar ke apa, susah lah. The aim tu sebab nak prevent aspiration je. Tu je. Okay, any other questions?
So far tak ada question. Ada siapa nak tanya soalan lagi tak?
Tak ada aku Syukurlah, saya pun dah nak kena cari air ni.
Okay, thank you Dr.
Okay, thank you everyone.
Doctor.
Okay, thank you.
Thank you everyone. Thank you Shafiq.
Okay,
Thank you, Liana.
Shafiq. Thank you Liana. Okay, good presentation. Okay, thank you. Bye.
Thank you, Doctor.
Okay.